A consultation is going to be an appointment for the patient to finally meet with the radiation oncologist regarding their treatment. So this is the first step for the patient. They have done, probably a lot of paperwork beforehand. They may have to do more when they come for their appointment, but this is the first time that they are going to treatment with radiation therapy. So this is the very first start of that. They are going to first usually meet with the nurse, and they'll do their weight, their height, blood pressure, temp, pulse, and respirations. And then the nurse might go over the paperwork with them just to make sure that they got everything they needed and if they have any questions. Then they will bring in the radiation oncologist and they will go over their medical history, kind of again, but a little bit more in depth and regarding how that will affect treatment. They may look at images that they've had from previous MRI, CTs, PET scans, and then if they had any surgery, biopsies, all of those things, the radiation oncologist has the potential to go over. And I think that looks different for every patient. I know that with the radiation oncologist where I was, he really liked to show the images to the patient to give them the visual of this is the area we're treating and these are the structures that we are looking at being concerned about that are surrounding it. So if we're doing the breast, then we're concerned about the lung, the heart, the spinal cord, the other breast, the other lung. So he was really good about that, showing all of that, and then going a little bit further with the test results and how that affects what type of treatment would be best for them with radiation therapy. Typically, the radiation oncologist will also do a physical exam during that time frame of the location of where the cancer is. So even though they have the imaging, they may still want to look at the physical evidence. So especially for things like breast cancer that they can see and they can feel very easily, they may just want to do a little double check to make sure and kind of get a rough idea of the patient's anatomy and where that tumor is located or where it previously was, if they have a scar from surgery, if they're going to have to do anything special because of said scar. Other places where it's a little bit more challenging to just identify right away, they may have to do a little bit more of a personal exam, like for things like cervical and prostate. But these are things that the patient's experienced before. They are a little bit more uncomfortable, but they know that it's probably going to happen again until they are through their treatment. The radiation oncologist is then going to explain what radiation therapy is and how it can be utilized to help treat their cancer. So in certain circumstances, it's helpful for treatment to actually cure a patient, and the radiation oncologist usually has statistics memorized for the patient to give them an idea of how this could help them long term. There's also palliative treatment. So that's going to be if a patient is stage 4, there's a lot of things going on within their body that we're not able to treat everything. But if there's an area that's causing pressure or pain, we may be able to shrink a tumor in that area with rad therapy to help the patient with their symptoms. They will also go through the potential treatment options. So if we're looking at comparing external beam versus brachytherapy, if we're looking at IMRT versus 3D, if they're looking at just certain things that they might be doing for the patient. They're going to go through all those as well as the benefits and the risks of each of those. Obviously, every patient and every cancer is different. So the location and what he's explaining to the patient will look different per consultation. At the end of this, usually the physician gives the patient time to ask questions, especially if they have loved ones with them. They usually will bring somebody for support, maybe a couple people, and that's always helpful for them to ask questions. What will this look like 10 years down the road? What will this do for side effects? How tired is this patient going to be? Are they going to be able to work? Do they need to take time off of work? What kind of questions that the patient might have, but also things that the loved one might be thinking as well. So this is really just a very large appointment. I mean, these can last for an hour, hour and a half, depending on the individual patient and how much the radiation oncologist shares, and to really feel like that they have given the patient enough time to make a decision. After the patient has received all of this information, they then get to decide what they want to do at the end. They may take time to think about the treatment so they can go home and think for a few days or a week. to identify the benefits versus the risks and then let the doctor know. Or they could agree on the spot that, yes, I want to go through treatment. I want to go ahead and do this. They also can just flat out say, I am not interested in this treatment. I don't want this. So the patient has all of that right. So they can revoke their consent at any time that they want to continue with treatment or to discontinue. If they do agree that day, if they decide to go forward with it, they will have to complete informed consent. So they've already gone through all of the benefits versus the risks and things like that, but this is a document that actually has it written out. So it explains all that information that they've already talked about, but they will go over it once again just to make sure that the patient doesn't have any additional questions. And that way they know that everything's been explained to them. Then the patient or a guardian, if the patient is unable to be determined as competent in order to be able to sign. So if they're a minor or if they maybe have a certain type of disability and they have a guardian, then that person must sign instead of the patient. And again, consent can be revoked at any time. We can get 90% of the way through the treatment and they say, I don't want this anymore. And that's their right. They can stop. So after all of this, the next thing that we're going to be doing is we're going to be moving on to what is called simulation. I included just a few pictures here looking at what could possibly be the scenario for consultations. So they're going to be in a normal doctor's office type setting. They're going to have things just like when you go to a clinic. They're going to have a blood pressure machine so they can take all those vital signs. They're going to have usually a sink and a countertop with some storage in there, so cabinets above and below usually. They're going to have a normal exam table for you to sit or lay down on, and they typically will have a couple extra chairs there for loved ones as well. And then the physician and the nurse will work side by side to help get you through the information. Typically, they're going to have a computer somewhere within the room. They may also bring their own laptops, just depending on your facility. They're going to bring in your chart will be there, and they will also then start typing information that you might add or clarify on. Other things they might have. So over here on the wall, you can kind of see in this picture down here, they have the scope that you're able to look in the ears, as well as if they want to take a look in your mouth or just have a flashlight to kind of identify things. So there's going to be a lot of normal equipment within there so that they can do just a regular physical exam and check in with the patient. So here is an example of a consent form for breast cancer. I just pulled this down from a website that I felt like this was a very beneficial consent form to look at. So it'll already have all the patient's details filled in, as well as the radiation oncologist, any special requirements. It'll have in what type of treatment. So this would be highlighted as breast, and then they would say if it's left or right. They would say if it's curative, what type of treatments they also may be receiving at the same time. And then on the right-hand side, it goes through all of the short-term side effects. So things like tiredness, skin irritation, itching, and then it goes through some of the less common ones. So swelling, changes in texture, even very much rarer than that, sore throat, skin blistering, inflammation, things like that. And there's more information coming on the next slide as well. Here's the second half of that informed consent. And so they listed out the late or long-term side effects for the patient. So if they have any issues with breastfeeding, skin discoloration later on, or changes to the appearance of the breast, smaller things could be shoulder stiffness, swelling of or lymphedema of the arm. Again, that's very uncommon for patients. And then the rare options are, fibrosis, increased risk of heart disease, decreased cardiac output, skin changes that are very significant, and a different cancer in the treatment area. So those things are very rare to happen. You may also see that there's rib fracture on there, and that's just due to the fact that if a patient already has very thin, brittle bones and we treat in that area and the bone gets a lot of dose, it just becomes very, very fragile and it has the opportunity then to have a fracture. Again, that's very rare for that to happen. Then we kind of have some statements from a healthcare professional of things to consider And with all that involved, we are going to be able to have the patient go ahead and sign and date. And then obviously we're going to have the physician sign as well. So that way everything's documented. Occasionally we do have to have the nurse sign as like a third party, to ensure that there was just additional people involved. So I really like this informed consent. This is very different than what I had at my clinical site. The ones that we had at our site was a lot more cut and dry. It wasn't, I feel like this one's very easy, simple to read, and it's pretty, as far as an informed consent can go. But the one that we had just seemed very, very dry, very straight to the point, document. So I like this one better. I think it's nicer for patients, but obviously it's going to depend on where you are. For simulation, this can be completed on the same day that they sign their consent forms at consultation, or it could be done in the future. This is obviously going to depend on the type of simulation they need to do, the scheduling of the facility, and just what your therapists are able to do that day. So, where I was, for radiation therapy, they tried to get patients worked in if necessary right after, consultation, because some of them were driving almost 2 hours from rural hospital areas. So those hospitals would not have radiation therapy. Therefore, when they would drive those couple hours to us, we didn't want to have to make them come back another day for simulation if we could avoid that. And so in simulation, our job is to create a position for the patient to be in that they will be able to reproduce every treatment following. So during this time frame, we're going to create immobilization devices to help hold them still, create reproducible markers on the patients so that we are able to align them to our lasers, and then also things to position the patient accordingly every day. Well, obviously, the most important thing here is going to be producing images to create the treatment plan, because if we don't have a treatment plan, none of it else will matter. So we have to do our imaging, whether that's with CT or MRI, and we'll make sure that they are enough quality. They don't have to be diagnostic like we would in regular CT or MRI, because we already know the patient has this cancer. We are just trying to find the structures that are surrounding the cancer, as well as what are the margins of the cancer. As I mentioned, we can do this through CT or MRI. So I would say a large majority of them are completed with CT because it has been around for a long time, and most of our linear accelerators run off of CT for dose calculations. So even if they do MRI, sometimes they still have to get a CT to figure out dose calculations. One thing about the MRI though is that it is much more expensive. There's not very many that are out there, and as I mentioned, they're just gonna have to get double scanned if they need the CT dose calculations. But that's gonna be what we're gonna be using, either a CT or an MRI machine. They do look similar, but obviously they function in a very different way. CT is going to use ionizing radiation, and then MRI is going to use a very, very strong magnet, and then pulses in order to change the directions of atoms. Our mobilization devices are split up typically between two large categories. So one of them is going to be masks, and these are going to be used for patients to hold them in the same position for treatment of head and neck cancers. So with this, it does cover obviously the head, and sometimes we use the bigger masks, which are going to go down into the neck and into the shoulders almost. But some patients only need the true like brain head mask. These are made of thermoplastic, meaning thermo is heat and plastic is obviously plastic. So when we heat the plastic, it's going to become very flimsy. So it comes very flat, and then we're going to place it in either a hot water bath, or they have like these ovens that are almost like little easy bake ovens, that you can get, and it will warm up the plastic enough that it becomes malleable so that we can use it to help shape around the patient. So this should be very warm, but it never should be hot. We always tested it on our own skin right after it came out of the hot water bath or the oven, just to verify before we place it on the patient's face. Different shapes and sizes are going to be dependent upon the treatment and also what manufacturer you get your masks from. It's kind of like out in the healthcare field, whenever you are purchasing different utensils or items that you need, they're all going to be a little bit different depending on which manufacturer you bought them from. So same thing here. They can be different colors. They can have slight different cutouts for your eyes or your mouth. Some of them have holes on the sides. Kind of just depends. But it's going to clip into what we call our head and neck board. So this lays flat on top of the table, and then it has some little clips around the outside, so where we can actually push in our head and neck mask so that it stays to the table for security. We also are going to have to mold the landmarks that are most prominent on our face. So things like your chin, your eyes, and your nose. So what we'll do is, usually there's two people that do this. It makes it so much easier if you've got to. So when you pull the hot water bath open and you get out the mask, you're going to bring it over to the patient, check the temperature, bring it down on top of the patient's head and neck, and then you are going to start kind of just pushing a little bit, just gently on the mask, and you're just going to try and start forming it around the shapes of the landmarks. Then as it's starting to cool, which it usually cools in just a couple minutes, once it starts to cool, those landmarks will be more solid. And so that will help take the shape. And then once it's completely cooled down, then we're able to see that it's in the shape of the patient's face and neck. So that's what we're looking for. Other accessories that these patients might need, especially if they have something like esophageal cancer or mouth cancer, we may have to do a mouthpiece or a bite block. So this helps push the tongue out of the way away from a potential cancer that we're trying to treat. So those ones are extremely uncomfortable, but basically we have a bunch of thermoplastic beads that we are going to kind of shape, ball them together, and then put it into the patient's mouth, and they're going to just kind of rest their tongue on it. And those kind of like the big clump of the beads together, we usually put a tongue depressor inside of it, so that way the tongue depressor is sitting outside the patient's mouth. They're kind of just put their lips around it. I have a picture to come up to show you. It's kind of hard to explain, but it's going to help. So then also when the bite block or the mold is now dry and cool down, we can pull it out and it will be in the shape that we need it. We also can put lead BB markers on the mask in case we're trying to mark where the laser alignment is. So we can draw like the actual crosshairs, but we can also put little lead BB markers if needed. Here are multiple examples of our thermoplastic masks. So they come flat, just like this picture up here. I'm going to change my blue marker. It's not really standing out very well. So this picture up here, they just come flat, and then we can place them either in the hot water bath, which is kind of this middle picture in the bottom. It's usually filled with water, obviously, and you can see the flat mask within there. Or we can use kind of like the easy bake ovens. They are a little bit bigger than what the kids use these days, right? But then we have them laid onto the trays, and then you close it and it will heat it up. So as we are forming it, like I mentioned, we're going to have to kind of conform to the shape of the patient. So they're on a head and neck board right now, and it has these little clips that just kind of rotate over on top of the mask. And so as they are pushing on just very, very gently, you don't have to push hard, on the chin, they're pushing on the nose, the eyes, and then they're also kind of pushing at the top of the head. Sometimes you have to do that if the patient has like a lot of hair that's in the way. You can help press down on the top to help conform it. If you have the whole head and neck, so that's going to be all the way from the head all the way down to the shoulders. And this one's a little bit different. It doesn't have like the little clips that just like slide into place. These ones actually have forceful clips. So you have to like press down and they clip into place. It's like a little pop when it clips in. So they usually have one here, 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 one at the top of the head, and then all of these ones will be repeated on the other side. And then we have another type of mask here. This one we usually use for like stereotactic, where we want to make sure that there's as least amount of movement as possible and changes between treatments. So what we can do here is we have the headboard right here. So we have the head and neck board, but then we also have a little cradle. So the cradle clips down into the head and neck board, and then oftentimes we'll put a little sponge or a head pillow behind where we're going to be placing the patient. So this is actually two pieces. So there's going to be one flat piece that lays just right here. And so when the patient then leans their head back and they rest on that pillow, we're going to put our hands cradling the back of the head so that way the plastic will mold to the back of the head. Then, once that's hardened, we will then bring over the top portion here and we will conform it to the patient's face. So it is much tighter on the patient, so that can be challenging, but it will hold them more still than some of these other ones. And so that's really important when we're treating things like the brain. So here's the examples of what a bite block could look like. So this green one's a little bit newer, something that we did not use at my facility, but it's kind of in the shape of a retainer with the portion that sticks outside to keep you from losing it in your mouth. And so the blue part is where the patient will actually bite down on, and it's going to be that thermoplastic molding again. So once they bite down, once it dries and cools down, it will be able to take the shape of the teeth. So then when you put it back in their mouth the next time, it'll fit in there just right. But this can either lower the tongue or raise it up out of the way if needed. Here's what it looks like when they are in a head mask. And so with these patients, it does stick up obviously from the mask a little bit, so we can conform it around the bite block. Some of our patients, they complained that it felt like it was kind of being like pushed into their mouth by the mask. So what we did at my facility anyway, was we would kind of stretch out one of these holes at the top for the thermoplastic mask and just move it out of the way. That way there's not much pressing on the actual bite block, and so the patient just has a little bit more comfort involved. What I am most familiar with is this customized mouth or bite block. So what we did was we have these thermoplastic beads that we'll put in either the hot water bath or we'll put it in with the oven, and they have like this kind of like this mouthpiece that's just more narrow than the green one that we just looked at, or mostly what we used was just tongue depressors. So then once the beads come out and they're malleable, we put them on the end of the tongue depressor, and then we'll put it in the patient's mouth. So we can either use it to depress the tongue away from like the roof of the mouth, or we can use it to raise the tongue out of the way if we're treating the bottom of the mouth. So what that looks like up here is A and B. So it looks like we're treating right above the mouth, so the top of it, kind of into the sinuses within the face. So when we're treating this area, we're extending out from a large area. And so we're trying to reduce the amount of dose to the tongue because that can give more irritation, pain with the tongue, pain with swallowing, lots of things. And they can lose their sense of taste as well. So in B, they have done nothing with a bite block. So they have just left everything like normal. So where we're being treated here, this is a lot of dose. The tongue, top of the tongue is right here. So they're going to get quite a bit of dose to that tongue tissue. If you look at A, this is a bite block. That's why it's just kind of black. There's just nothing really there. And then the tongue has been depressed down. So that is going to help get it out of the way of the treatment field. And so that will have significantly less side effects because it's out of that treatment location. Here are some additional marks we may have to make on the mask for the top row here. So when we are trying to identify where the lasers line up, we can put a crosshair, and then also you can see, I'm going to change my color again so you can see it a little better. There's kind of like this little sticker, this yellow sticker that's on top of the patient. And there's a little lead BB right in the center. So that can help us mark exactly where those laser alignments should be. And then we can actually see them when we do our imaging and daily kind of location of where things are located. And then on the middle picture, this is a full head and neck patient. What they have done is they just put tape across everything and they've just marked where their lasers come from on either side, just to help them with alignment and make sure that nothing is off, left to right, up and down, all those things. This last one on the right-hand side is looking at a whole brain treatment. And so it's demonstrating the whole field that's open and allowing for radiation to pass through. So we can actually draw that for our whole brains. So they have their original laser marks right here on the tape, but then this this line is showing you the collimated border of where radiation is being allowed through. So everything that I'm drawing here, connecting right here, is getting treatment on this side, and then it's also going to get it from the other location too. So you can actually see that on the MLCs here from in the gantry. The gantry is kind of on its side. So you can see these lead MLCs, they're in the shape of what we are treating on that side. I also put in here that some locations, especially pediatric hospitals, a lot of times will have artists or the therapists become the artist where they will help paint different kind of components of the masks just to make it a little bit better of an experience for the patients. Because for kiddos, this can be really scary. I'm going to put a mask on you and you're not going to be able to move. And I'm also not going to stay in the room with you. And so trying to get them excited about, oh, I can look like Elsa, or I can have a rainbow or look like Pikachu. So some of these things are acceptable. Some locations, the facilities may not allow you to paint on top of these until after the patient is done, just to prevent any kind of additional interactions with the paint and the photons, or prohibit the depth dose. If you put too much paint on there, it's going to act as skin. And so the depth dose is going to be delivered differently. So it kind of just depends on your facility and what they allow you to do. But I've heard of a lot of places that do this because it helps make the patient's life easier. It helps make them come to treatment and not be as scared. And so that's a wonderful thing if they're able to do that. They also can decorate the rooms too. I've seen people decorate the head of the gantry, make it like a Pac-Man theme. So it's like the big thing that's trying to come and get you. I mean, maybe that sounds a little bit scary, but it was really cute the way that they did it, I promise. I've just seen a lot of different components where they have decorated for each holiday to help make the patients just feel a little less scared throughout this hard journey. The second main immobilization device that we'll use is called a vac lock. So these are going to be like big old bean bags that we're going to suck the air out of to help position these patients. And they're going to be used for treatments of the chest, so the torso area, abdomen, pelvis, and then there are some for other types of cancers where they make smaller vac locks that you can put around like hands or arms, legs, whatever necessary for that. But once we have this vac lock, we're going to suck all the air out, put it underneath the patient, and then we're going to kind of press the vac lock into the body as we're sucking the air out. And when you do that, it's going to conform to the shape of the patient. And there's a little valve on the end that we'll just cover to make sure that it stays and no air is getting back in. And it'll stay like that throughout their entire treatment. Obviously, as I said, there's going to be different sizes and shapes depending on what type of treatment. Some of them are whole body ones. Some of them are just kind of like a rectangle for the chest or the legs or the pelvis. But other things that we might need to do with this is to make special marks on the bag with tape and marker. We may have to use a block in between their feet to help hold them still, a rubber band around their feet. They could have a knee cushion. We usually put the knee cushion underneath the vac lock. So we'll put the knee cushion down, put the vac lock on top of that, and then put the patient on top. That way we're trying to hold them as tight as we can. There are some instances with rectal cancers. We also can do things like rectal tubes to help escape air that might be trapped in there that's causing the field to change size. So a few things that we could do as accessories with the vac lock. So here's some examples for you. When we first get the vac locks out, they're just going to be kind of flat and just flopping around because they are just like a beanbag. So this is what it looks like before we suck the air out. You can see it does have the valve here at the bottom where we will attach it to a machine, which is this right here. There's just a tube on the end. We attach it, we hit this, turn it on, hit the start button. It just sucks the air out. Sometimes they have a remote, or here they have a foot pedal, which is really nice. It leaves your hands free so you can shape the patient and just step on it with your foot. When we suck all the air out, this is what it's going to look like. So this one's a little bit different of a vac lock. It has more of like a shiny kind of layer to it rather than most of them are kind of like a matte texture. But this one, you can see where the patient's head was, their shoulder, and then going up into their arm when they had their arms raised above their head, comes down to their armpit, and then down by their side. So all of this off to the side is all hard and it's shaped to the patient. So we'll keep it like that throughout their entire treatment and lay it underneath them each time. Up here at the top, we have a couple options. So this is for a patient, probably a breast or a lung treatment. And so what they have done is they have brought the arms up and they have the vac lock underneath the top of their body, kind of their shoulders and their head to help keep them still and out of the way. There are handlebars up here for the patient to hold on to, so they're not just kind of like letting their hands just dangle, because that's kind of a problem if they don't do it the same every day. Same thing here. This is more of a whole body vac lock. And so we're getting all the way up from the hands down through the torso and the pelvis. So these ones, it has a little bit more of like a flap on the side. So we will make sure we push those up really well to confine and conform to the shape of the elbow and the arm and then armpit and then going down by their sides. When we store these, a lot of places will store them hanging on like a clothing rack. So they usually have a hole right by the valve where you can just place a hook on a clothing rack and then just hook it on there. And again, this is that valve there. We will mark these with usually a Sharpie and a piece of tape. So we'll mark on there what the patient's first and last name are so that we don't accidentally get them mixed up with somebody else's. And you're not trying to pull it and think, oh my gosh, which patient is this one? I can't remember what this one looked like. Doesn't matter because we're going to have their names written on there so we can help identify them very easily. If we know that our patients are going to have to do a breath hold of any sort, or if we're going to be monitoring them very closely, we will do what's called gating. So we will look and evaluate at their breathing as well as when they're breathing, how does their chest and abdomen rise and fall? So what we do is there's going to be a camera somewhere throughout the room, usually just right across from the CT machine, looking straight down on the patient. And we'll put a kind of a cube that has laser alignment marks on either side to align it to get it all centered correctly. And we're just going to kind of tape it to the patient on usually on their abdomen, kind of like where it's coming up into their chest. And the reason we do that is because that's where it's going to move the most every time you breathe in and out. And that camera will pick it up. So what we'll see here is during this time frame on this little clock, it'll tell you when they took a breath in and when they did not. So it's just going to monitor as you take a breath in, how does your anatomy change? Drops down. Breath in, breath out, breath in, breath out. So that helps them time everything and identify how much structures are being modified when they are moving things. It also will help us figure out how well can my patient hold their breath. Because sometimes we get older patients that are already on oxygen and they struggle to hold their breath. And so if we need them to do, it's called DIBH, deep inspiration breath hold, that can be challenging. So the dosimetrist and the radiation oncologist are going to have to figure out a way to work around very short breaths when they're doing their treatment planning. Some additional items within simulation. We do oftentimes give patients tattoos. These are permanent landmarks where our lasers line up, just that center point. We give it just a small dot, just like a freckle. We are not trying to do a very large one, but enough that our eyes can pick it up. So they're going to be using a needle and ink. Where I was is we just had obviously single-use needles. We weren't reusing them. And then we would use the same bottle of ink, but we would we would pour the ink out into the little tray that the needle came into. And then we would just dip the needle in the ink and place it under the skin. There are some out there that already have ink built into them. So this is called an AccuTat. And so they just pull off the top portion of it and you have your needle at the end. There's ink already within there. You just squeeze that a little bit to allow the ink to go underneath the skin while the needle's there. You're not going in very much at all. And actually, you don't really go in a straight shot. You come in at a very, very shallow angle to the skin because you're just trying to get right underneath that top layer of skin just to give them a little bit of ink. We're not going deep. It's not supposed to be a true long-standing tattoo. This is just something for us to have it more of a permanent landmark. So therapists get to do this. We learn how to do that. And we can use blue, black, or red. I know a lot of places try and avoid the red because it does sometimes actually blend in with freckles because it ends up coming more like an orangey or brownish type color. So blue and black are much easier to see. Obviously, depending on the patient's skin type and color, it can be a little bit challenging even then to still pick up on those colors. With post-processing in simulation, we usually are going to have to do reformations. So all of our imaging, whether it's with MRI or CT, starts out in the axial plane. And so that's because the patient's laying on our table and the coronal or sagittal planes are going to be off to the side. Okay, so when we first take our imaging, we're going to be taking these axial images like this one right here. And that's what normal CT looks like. But our software allows us to do post-processing where we can get those coronals, which is this image here, looking at it from the front, and then we can get sagittals, which looks at it from the side. This just gives the dosimetrist and the radiation oncologist more images to evaluate and ensure that we are reducing the dose to the surrounding structures. So for our simulations, let's talk specifics for breast cancer. When our patients come back to us, we're going to have everything already set up. So we're going to have to make sure the room is prepped and have any paperwork that the radiation oncologist will give us. They usually have a paper that states the exact anatomy that they want and what the treatment's going to be, and if they want us to do gating for anything. So we're going to do any kind of warm-up procedures before the patient gets there. So if we need to do quality assurance and then also make sure our tube is running and up and good. We're going to do immobilization devices, have them prepared. So I know that with breast cancer, I'm going to do a vac lock. So I'm going to bring that and have it set up on my table. I'm going to get a leg cushion that goes underneath their knees to help take some of the pressure off of their back and their spine. I'm going to get a sheet laid down on top of everything for comfort. I'm going to ensure that if I have to know that I'm going to be doing tattoos or anything, I'm going to have all of that ready to go. So I'm going to retrieve my patient from the waiting room, or if they're still in the consultation room, then I'll get them there. I'll explain the whole process from start to finish of what we're expecting to do. So I will let them know that we're going to have them lay down. We're going to make an immobilization device. Then we're going to do a little bit of alignment and look at lasers, make some marks. We're going to raise you up into the machine. You're going to go in and out maybe a couple times for your scout imaging to plan from start to finish where you want to be. And then I said, then we'll do the actual scan and we'll take some pictures of your setup and everything and give you some final marks before you leave. So at that point, I'll have my patient undressed. So they're going to have to take everything from the waist up off, including any kind of necklaces, any other jewelry, like long earrings that could be in the way. We're going to create that immobilization device. So usually 2 therapists will do this to help make sure that you get a good quality immobilization device. So that vac lock, I'm going to hook it up to the machine and I'm going to press it up against the side of the patient in that position. And with their arms up, the arms need to be up and out of the way for breasts. And we'll suck the air out and it's going to conform to that patient's body. I will seal the vac lock after I'm done, put the machine away, and then I'm going to go ahead and mark on the bag with tape where the mid levels are. So we're going to mark both mid-sagittal and then we're going to mark mid-coronal plane to help us identify exactly where the lasers align. Then I'll move my patient into the scanner. I'll do my scout imaging. So we usually do an AP and a lat scout image. And from that, I'll look and see how much anatomy I need to include for my start and stop locations. And then I'll actually perform the CT of that area. After I'm finished, of course, if I had to do gating, I would then do that with the CT. But then from there, I will process my images by creating from the axials, we'll turn them into sagittals and coronals. That usually is really fast. So usually you can hit the button, it starts to automate all of that, and you can go back into your patient and you'll take pictures of your setup just to make sure if anybody after that day has questions, they can look back at their simulation photos. If they need tattoos, I will do that at that time as well. And then I'm going to help the patient up and down, let them get dressed. see if they have anything else they need to do to that day or any help with anything. And then I'm going to send them on their way to go home. And I'm also going to send this entire study from the computer. The reformations of sagittals and coronals should be done at that point. I can then send that on to the radiation oncologist. So then that simulation paperwork and everything should be done at that point. And here's just some imaging of what that might look like. So up here, obviously I've got my back lock again. I would place that on the table underneath the patient. And so they're going to have this board where they're able to raise their arms up above their head and hold on to said board. So you can kind of see that right here. And then this patient's on an incline board. Where I was, we did not use these, but some radiation oncologists like them. It just means that they can raise them up to a certain degree when they do their breast imaging. This just helps the breast fall more with gravity, like towards their feet, rather than sometimes if they have large breasts, they can kind of, when you lay on your back, settle up towards your neck. So that can help with that. But we'll mark on the patient where our laser alignments are, and get a back lock ready if needed. This one has built-in armrests, so they're able to use that. So these are the marks that we can place on afterwards, and we can actually put little sticky tape over the top. Some of them actually have the little crosshairs as well. So you can mark with your Sharpie and then also put a sticker on top that has a crosshair, or you can Sharpie the center of it as just a hope that it'll stay together. We also can image where we have those crosshairs with the lead BB markers. This actually happens a lot in CT with our simulations, because that will truthfully show the dosimetrist and the radiation oncologist where your lasers were. And so this can help you on your first day of treatment. When you go in, the dosimetrist can say, all right, I know for sure based on this little lead marker where they were aligned. And so if I need them to move 5 centimeters to the right, I can tell them that, and they can go off of those same marks. So those little lead BBs are very helpful with that. And then this is just another version of the gating block that we would put on the patient's belly. So if they're going to be doing the DIBH, we can bring that over the top of the patient. It'll just rest up there. Sometimes we use tape to hold it still. And then as they breathe, it'll monitor that. And if we tell them to take a breath in and hold it, we'll see how long they hold their breath there, and kind of what the difference is in the depth wise with how they breathe. And here is what the treatment plan could look like afterwards. So here was the original CT that we did for the simulation. The dosimetrist was looking at it and identified where they wanted to treat. They found said tumor that they were going to treat, and they were marking specific areas they were concerned about. And then this is a different patient on the right-hand side. But this is how they could have treated it with volumetric arc therapy. That's why it kind of has the rainbow on it. And you're seeing all the different colors as the amount of radiation dose they are receiving. But they would have treatment that would go all the way around the patient and interact all throughout this region. That's what's getting the dose. So CT is very important for us to be able to identify. And then also we have to make sure that they're in that same position every single day. So we're treating this same area that the dosimetrist has outlined. So next, let's talk prostate cancer. So this one is going to be a little bit more challenging, but we're first going to have the patient obviously fill out consent forms and everything, but then they are going to have the room set up again. So we're going to make sure we have the paperwork from the radiation oncologist of what we're going to be imaging. We are going to make sure that we have our immobilization device, which is a back lock, placed on the table. Typically with this, we're going to have like the leg cushion. It's going to be on the table, and we can actually lock the leg cushion into place. I forgot to mention that. There's like a little bar that will go across the side of the table that will lock into place. You can kind of see the little notches on the table. I don't know if you can see this very well. There's little notches on the side. So we do have a bar that will extend from one notch on one side to the notch on the other side. And so we can actually make sure that leg cushion stays in at the same spot every single time. And we'll mark that number in the patient's file. So if anybody has any questions, they can look at it. But then once the cushion's down, we'll put the back lock on top of it. So that way, when the patient lays down, we're still conforming to the shape of their legs and their pelvis as it's laying on the leg cushion. We will get the sheet laid down on top for comfort. We also are going to need a like a head cushion. So it's just like a little kind of silicone piece that shapes to the back of the head that we lay up at the head. So we can kind of move that around. That's not really in the imaging, or we're not too worried about that. So that doesn't have to be locked down, but we can use that for the patient's head for comfort. And then obviously, if you need to do warm up procedures, you should have done that in the morning or before this patient comes to you. But we'll finally go get the patient either from the consultation room again, or if they're in the waiting room. But this is a little bit more challenging with prostate patients, because if they came for their simulation and only their simulation, then we have given them specific instructions. But if they came from their consultation, then they probably don't know what they need to do. And so with prostate cancer, we want them to have a full bladder, so full of urine, and we want their rectum to be completely empty. And the reason for that is it's going to help position where we are trying to image and then where we're going to eventually treat. So it helps push some of the structures out of the way and just it gets it in the best position possible to treat prostate cancer. So if they came from their consultation, they may have to sit out in the waiting room for a while, and they may have to use the restroom and then drink a lot of water before they can come in to us for simulation. Once they are ready for that, they come back to us and they undress. So these patients, a lot of times we can just have them lower their pants and we can just cover them with a sheet instead of having to make them take everything off from the waist down. Because you got shoes, socks, the whole 9 yards. So we just kind of have them lower their pants below their pelvis, and we'll just cover them with a sheet. We are going to obviously make the immobilization device at that moment. So we are going to push the bag up against their pelvis and lower legs. With these, sometimes patients need to have a block between their legs and then a rubber band around the outside to help hold their legs into place. If you have a specific feet holder, then you can place that at the end of the table. That works too, but trying to make sure that they can't move their feet. That changes the anatomy within your femoral head and neck. So we want to make sure that they can't move their legs inwards or outwards. So we'll shape that immobilization device. We'll seal the valve once we've got all that air sucked out. We'll mark mid-sagittal, mid-coronal planes with a Sharpie on top of a piece of tape. And then we're going to move the patient into the scanner. We'll do our AP and our lat scouts, and then we're going to go ahead and scan that area. We have to make sure that the bladder is very full and that the rectum is empty. So if we do it and we see the bladder is basically non-existent, we cannot count that simulation. We are going to have the patient get off the table, go drink a bunch more water, and come back in 20, 30 minutes, and then we'll try again. Same thing with the rectum. If it's not empty, we're going to have to get them off the table and try and get them to go use the restroom before we can image again. So we want that to be a good standard, a good foundation for the rest of their treatment. Once we are done with the images and we're happy with them, we will then hit the post-processing features where it will reformat into our sagittals and our coronals. We can go in and take care of the patient by setting up, taking setup photos. We can go ahead and get them up off the table. If they needed extra marks, we could have done that too before we get them up. And then we'll let them go. And again, send these images on to the radiation oncologist. So here are some of the images that I have for prostate patients, or I do have one female in here and she was for a gynecological cancer. But we're going to have our vac lock just like we use with breast cancer, but it's going to be more of a vertical format, and it's going to be underneath the pelvis and the lower legs. So you can see that here with this patient as they're laying on the table. It encompasses their bottom of their hips and through their legs. Sometimes, like I mentioned, we're going to need a block in between their legs. So we'll situate that vertically and then put a rubber band around the block and the feet to help them stay in the same position. We will align from the side. So you can see that here. We're going to align from the side and find our laser marks and get everything marked up the way that we need to. This is on the actual gantry, but for the linear accelerator, but this was kind of a good picture of the lasers coming from the side. We can look at their marks that we're going to be making with Sharpie, and then we can cover them with a sticker, just like with breast cancer. And our imaging was done with the lead BB markers to help the dosimetrist identify where our alignment was. If you have a fancy location that has a knee cushion and a foot holder, this is what it could look like. And it will just clip into the sides of your table. It's got these little clips to meet where those notches are on either side. Where I was, we just had like a little knee cushion that had a bar underneath it that went across that we clipped in. And then we just use a sponge and or a block and a rubber band around the feet. For their hands, to make sure that they keep them up on top of their chest, we can give them a diving ring, or this is more like a foam ring where it just helps keep their hands up out of the way as a reminder that they can't put it down by their sides. As well as if somebody has a very large belly and chest, they may not be able to reach very well across their chest and hold that position the whole time. So using the diving ring or foam ring definitely helps. And here is what our imaging would look like on the left-hand side. So we've got our patient on the table, and this is a scan of the pelvis. And so we're able to see some of the structures here. We're not at like the best location to see bladder and prostate and rectum. But over here, this is where they have the treatment plan identified with volumetric arc therapy. So we got the whole kind of 9 yards going with a full circle with VMAT. But here we are able to identify that they are treating this area very heavily. And then the rectum is back here. So we want the rectum to be as small as possible so it's not inside of the treatment field. That's why it needs to be empty. If it's full, it's going to stick out inside of the field, and then our whole situation is going to be off. Our prostate's not going to get enough, and then our rectum's going to get too much. And then obviously with the bladder being more superior to this, we could also align to that. The full bladder helps push the prostate down and away.